what are the potential long-term consequences of these clinical placement shortages?
Yeah, really scary stuff in my opinion. And again, I don't want to come on any interview or any written article and kind of lead by a kind of a doom, a prophesying doom or anything like that. But it is worrisome and scary for me. I've been in this field for about 30 years, 30 plus years now. I've had my foot in public health. That's where I started my career for 10 years in the Department of Health in Austin and did some CDC work. And then I moved into medical lab and academia the last 20 years. So I've got a foot in both sides of this. And I'll mention to you briefly public health. The public health workforce has seen since 2008, we have seen about a 20-ish percentage drop in the number of workers needed. I mean, that's 1 in 5, right? So I mean, that's a really big problem. Um, and I'll continue to preach this, and I hope the country hears it. I know they're hearing more of it after the pandemic. The pandemic actually did have an effect on public health funding and healthcare funding. I just don't want it to be temporary, right? So I'll often talk about we tend to have knee-jerk reactions in Congress and in other places, and it's natural. You have an emergency, a hurricane, a pandemic, an outbreak, a tornado, and you knee-jerk. You give immediate aid to those areas. You flood it with money and maybe resources, and then it goes away in a year or two. We've got to stop living like that. We have to take the old statement, prevention, is worth a pound of cure. We really need to think that long term. So we need a sustainable, ongoing, I would say, line item congressional support for public health and healthcare so that we don't run into these issues all the time. And that includes things like funding for scholarships and awareness for college majors in these critical areas, not just nursing and doctors, but the medical laboratory and public health systems, because nothing happens without our results, right? I mean, about 70% of everything we do impacts physicians and healthcare provider decisions. It's the single most important piece of information to healthcare is the laboratory result, right? It impacts from cradle to grave. I mean, every time you enter one of those places, your life is in our hands. And so we need to get that message across. We really are really critical for that. So if we don't get there, Olivia, I worry about the next pandemic. I mean, we had a little scare with monkeypox. We're worried about influenza. We're worried about malaria. We just seen some inductions into Texas and Florida. I mean, this is not going away due to all sorts of factors, including changing environments and climates and vector movement, and disease is going to start encroaching on other areas. So it's not going away. And so we need to be prepared for that. We need to be prepared by professional numbers, competence. We need to be prepared with stockpiles of medications and vaccines and resources to get things around the world so it's equitable. It's not just in the more economically structured countries. So there's a lot there, but that's my concern, is that it will impact absolutely the morbidity and mortality of our populations if we don't support both public health and healthcare medical laboratory professions.
Would you say this boom in funding and investment and resource, like post-pandemic or as an impact on the pandemic, is still going, or would you say you've sort of seen a drop off now?
I mean, there's been kind of a natural slowdown and drop off, but pleasantly we have seen some things happen in the U.S. The government has pumped in some major funding into the public health system, directed at what we just talked about. They've also done some things with healthcare. So I'm watching, as most people are, at least in leadership roles. Will that stay at least at a level that can help maintain it? You don't have to just pump in tons of money, but you need some ongoing funding that will match inflation and things like that. I mean, I love to kind of mention this to people because people don't always think about it, like the common person. The United States, and I know other countries do this, they they pump in tons and tons, trillions and billions of dollars into the military, into the Department of Defense. And I'm good with a strong defense, don't get me wrong. But guess what? Microbes, microbes have killed more people than most battles and terrorism combined. Why don't we take public health as seriously as our threats from what we consider, our enemies or our aggressors or things like that? I mean, because microbes are our enemies. They're a collective global entity. They do not care, as we saw with SARS-CoV-2 or with malaria or with monkeypox. They don't care who we are. They don't care what we look like. They don't care how much money we make. They don't care what color we are, what gender we are, what political party we belong to. It really doesn't matter. A virus only only exists to infect you and I, to amplify and to cause damage and destruction, in the human body or animals or plants. And so I just wished that the governments and others in power would understand that that's really our first priority. Nobody matters. Nobody gets to beat a virus, especially. They're so diabolical in what they do. They only exist to, multiply, amplify, and cause destruction. So it's just something that I think we need to keep our eye on the ball moving forward.
Yeah, you would hope post-pandemic that they would, and that they would see that threat. But I think it's one of those things where it's like out of sight, out of mind, and then yeah. So
Always,
hopefully,
right? I mean,
yeah,
it's
hopefully
always
we don't have another pandemic to then
yeah,
remind them. You would hope that they would take the precautions beforehand before we get to that stage
that's
again.
right. I mean, one of the things I say, and this is a quote, and I can't remember it exactly, so it's not my quote, but I mean, I've thought about this my whole career is, and this is public health. So we have to understand that this is the world we work in. This is how we have to deal with this from the public, because this is the response, right? If we do too much, if we pour too much money into something, if we prepare like crazy, we're looked as being kind of overzealous. We spent way too money. We're wasting money. We're overzealous. We're over cautious. If we do nothing, we're looked at as, well, you weren't prepared. So it's really this difficult thing. You're either way too, over prepared, or you've done nothing. And no matter what you do, you're going to be judged. So we need to find some common ground so that we can ramp up, that we can at least ramp up. And I do think we've learned some great lessons from COVID. One of the primary things we've learned is that transparency is critical. We need to think about multiple streams of supply chains. You cannot be locked into one country or one region for your supply chains. You really need to diversify, and you need to think collaboratively. One of the great things about COVID and the healthcare and public health here in the U.S. is that we've rekindled some really old coalitions, and we're still meeting sometimes once a month. So we're keeping those things alive to talk about other issues, whether it's diabetes, cancer, or an infectious agent. That's really important. So you have partnerships and you have people. Relationships matter in public health, just like they do in war. Relationships are critical. So you have allies, and you know who your enemies are, and you know how to get over those hurdles, and at least you have some people on the team that have lived through it prior, and so you have some ideas and you have a starting point. It's not just ground zero every time something happens, which is, as people die when you're sitting around trying to figure out how to test, for example, how to roll out testing to the country. We have to be better. We have to be better, and we must be better at both the national and state level and local level to get those resources out quicker. And so I think that's the biggest lesson we've learned.
Yeah, and I think that's a great message to push out there as well. Going back to clinical placement shortages, then, are there any successful initiatives or models being implemented in other countries that have effectively created more clinical placements? Because I believe in the UK we're also suffering from shortages where biomedical science students can't complete their portfolios. So is there any other countries that have gone through the same thing and basically come out of the other end with it with some successful initiatives?
Yeah, I really appreciate the question. And as you know, we've talked about this offline. I love traveling into the UK and elsewhere around that area. Wonderful areas to be. And biomedical scientist is kind of the synonym for medical laboratory scientist here in the U.S. So, I did some digging when I saw that question as something we might talk about today. And interestingly, in the literature, when you go into the literature, so I'm always going into the literature and to look at these things, there really isn't a lot of anything different. It unfortunately, as I mentioned, it seems to be a global problem. I got a couple of points here. I found a couple of articles that was looking at the UK, Australia. They were talking about the US as well and some other places. But when you started looking at barriers, some of the language around barriers to what they were dealing with, it's the same stuff but different wording. So here's some of the points: lack of time and heavy workloads, lack of staffing around shifts, lack of management and organizational support, lack of supervisor training and support. So one of the things we've started doing in the U.S. because of that very thing is sometimes the preceptors, the people on the bench that need to help train the student, they have no they actually have not been taught how to be a good preceptor, how to actually deliver that training. And so they're a little taken aback. They're already busy and overworked. So we've tried to start giving them more resources. For example, easier ways to streamline how they document student learning. So easier rubrics. Maybe they're online, maybe they're on their devices, so that they can kind of get through those a little quicker, just to save time, just to knock down some of the hurdles. And then lack of understanding and support. And this is talking about these preceptors. They feel like sometimes the upper administration, the C-suite, or whatever the situation is, they don't really understand how difficult that is to train a student and to bring them on correctly. And so it gets into lack of relationships and trust and understanding about what these preceptors and others are doing. And so it's kind of a complex thing, but when you look globally, interestingly, kind of the same stuff. They just can't get these clinical, you call them portfolios, we call them, competency hours. It's difficult. And so I'll tell you another thing that can happen, and we're seeing this in the US, is we have kind of these big programs that will offer online didactic coursework. Everybody loves online now, right? That's fine for the lecture piece. But when you start thinking about laboratory understanding and how to get basic skills like clinical gram stains and CBCs and type and matches for blood transfusions, I mean, these are life saving skills. You can't not do them well when you're teaching students. So you can't really do that online. You really do need a way to get hands on practice, even in the academic setting, so that when they go to their clinicals, they hit the ground at least with some level of practical and theoretical knowledge. It's a very one-on-one type of thing. It's not easy to crank out 100 people, with one teacher. It's really one-on-one, maybe one on two or three. You can't get too crazy with your ratio there. Again, this kind of leads to our problem of how do we do that? We're really busy. How do we bring in 4 students a year? I mean, it's a really complex problem. So those are the things we're working on. One of the other things I might mention is a solution that we're kind of been talking about in the U.S. is we're starting to look at programs. Let me give you an example. So I get 30 to 40 applicants, and I can only take 20. Well, maybe 50 miles away, there's another program, and maybe they're getting less numbers. They're only getting 10 applicants, and they actually have 15 or 20 spots. I'm now recommending. I've kind of been doing this anyway over my career here, but we're starting to look at making that more purposeful, like a national or state database, so that programs and hospitals are communicating real time, and they're like, oh, you've got 5 more students that are adequate. Please send them our way. Maybe we can provide some support for education funding. Maybe we can provide something to get them, or maybe we can give them a part-time job, so that they'll come move to San Antonio, for example, and go to our program and help us fill our quota. So that's one thing we're trying to do, is just to help fill up programs. We don't want any programs that have 8 empty spots. We at least want to fill the quota. And then what we're doing is we're trying to get programs to start finding ways to stretch. So this fall, we're taking 22. That may not seem like a lot more, but it's two more. And we're hoping to hold on to all 22 so that, over time you start building some capacity there to help the hospital systems. I don't think there's any major quick fixes unless we can somehow, and we are seeing universities do this, maybe work with big industry, like big reference labs. Like Quest is working with St. Louis University. ARUP out in Utah has kind of created its own training center. They tend to have more money sometimes than academic centers, and so maybe they can help shorten and improve that number issue. I've even mentioned to some colleagues and leaders that we really probably should actually look at the military, because they have ways to create and crank out sometimes hundreds of nurses or hundreds of PAs or hundreds of medical lab scientists in one area pretty quickly. They very efficient in how they kind of run things. So maybe we need to look at other industries, look at what other people are doing that's working well, and not stay in a silo. Just because we're healthcare doesn't mean we can't learn from IT or some other industry. Like, what are you doing, to improve numbers and get things turned around? So we're starting to try to listen and learn and just keep working with our funding and communication, to try to help shorten those gaps and improve those numbers.
Yeah, I think the the sorting them out to different placement locations as well, I think is a really good start. Because like you said, you don't want any gaps, because then there's no point in having any gaps, sorry, if you're not going to then be able to fill them.
Right.
But then if there's a shortage, you kind of want all those gaps filled. So I think that sounds
Absolutely.
like a really good start.
And when you think about it too, you think about what you just said is important, again, for the public to understand. I always tell people, you can't build a medical lab scientist overnight. You can't even build one in like 1 year. It takes time, and nursing's the same way, and physicians. So that is so important that you don't have empty slots, because if you're down 8 people, that impacts you for years. Like you can't back up and get those people. So you need a full class, you need a full cohort every time you run through, because and then you want to increase it too at the same time. But if you're leaving those empty, you're empty. You're not going to get those filled. So it's a problem.
Yeah, I guess it's not like if you have less slots one year, you can then be like, oh, we'll have four
That's
more
right.
people the year after.
That's
Um,
exactly right.
yeah, but yeah, thank you so much for that. That was a fantastic conversation. It always is with you, Rodney. So
Thank you.
thank
Thank
you
you,
for
Olivia. I mean,
joining
I
us today.
really appreciate it. I love you guys with respect to what you're doing. And as you have time, or, if you have other topics that I can help you find other experts, I'm happy to try to help. This is really a passion, and it's really important, both for all countries, really. So I appreciate your time with me.
We appreciate you taking the time with us as well. Thank you.
Awesome.